Hold on just a minute. We're going to start in 1 minute. Letting everybody file in for another minute. I'm getting a notification that Zoom detected a problem with my audio and needs to restart. So if everyone gets kicked out, that's why. All right, nothing happened. Okay, so anyone who wants to ask questions, you can do that. You can unmute yourself. You can also send questions through the chat. Does anybody have anything from the exam review sheet, for example, that could use a little bit more clarification?
Hi there. I was just going to say that I'm probably not the only one, but maybe I am, that could always use a little brush up on Icer and qualies. And I know we were looking at 3 different ways, you know, pros and cons of calculating qualies. So I guess it's not a specific question, but kind of a topic areas to look at more.
Yeah, so that question about the 3 different ways of eliciting QALY weights, it's not about the calculation of it, but how do you try to understand, okay, so what a QALY is, a quality adjusted life year. If you're in perfectly good health, then it would be 1 year. But if you have an illness that makes it to where the enjoyment of that year is about half as much as being in full health, then the QALY weight would be 50%. It'd be 0.5. Maybe you're just so sick that you can only do half of the things that you would normally be able to do. And as much as that sounds very much like a abstraction or just like an idea, it's actually used to make determinations about what kinds of drugs are going to be covered, especially in systems like the beverage model, where the government fully pays for everything and people are going to consume whatever care because it's free. So they have to make those determinations ahead of time about what they're going to spend their money on and whether or not, you know, a particular drug is worth covering. And so the quality adjusted life years that you gain due to a particular drug can make it either worth covering or not worth covering. And so how bad it is to have a particular disease is really subjective. 2 different people could have 2 different, you know, answers to that question of, let's say you had to have your leg amputated. You know, what percentage of a full health would you consider that life afterwards? So there are different ways for how they try to get at like the difference between full health and the state of being with this disease. So those are the three different ways of eliciting the quality weights from people. And so there are these different ways that they do it, and they talk about it in the textbook. I want to say it's chapter 14. I know I'll put all of those under 12, and some of them are not chapter 12. So one of the ways anyway that they do it is the visual analog scale. So people will look at like a sad face all the way to a happy face, and like the sad face is 0, the happy face is 10, and then it's like from on this scale, how bad is, you know, this disease? How much less bad is it after you take this drug? And so that's one way of doing it. Another way of doing it is asking people the time trade-off method, where they have to think about like a gamble between, you know, let's say you flip a coin and tails, you're in full health, and the other side you have, or I don't know, how do they phrase this? I don't know. It's the time trade-off, the standard gamble, and the visual analog scale. Anyway, those are the three ones, and they're all explained in the textbook pretty well in chapter 14. I don't want to get like the details wrong, but if anyone has any specific questions about those three, happy to talk about it further. Okay, we have a question in the chat. Hey everyone, would you be able to refresh on cost effectiveness analysis and cost effectiveness frontier, the main points and differences? Okay, so it's on page 289. I guess everyone saw that. So I guess that is definitely an area in which people want to go a little bit further. So cost effectiveness analysis in general is kind of that process of deciding how effective a particular drug is. And so qualies, it's one way of measuring the effectiveness of a drug. It's, you know, I mean, if a particular drug makes you feel better, how do you measure that? I mean, that's it's difficult to do, but also really necessary to do when you're trying to plan a health system or a health policy system. So cost effectiveness analysis is about putting into numbers. It's about quantifying the impact in well-being that is associated with a particular medical intervention, a drug, a treatment of some kind. So you might want to weigh two different kinds of therapies. For example, you know, this one drug that's a generic, it's been out forever and it's really cheap, versus this brand new drug and it costs a lot more, and perhaps it gives you a little bit relatively greater well-being. So being able to trade off between the two, or even just quantifying how much better one is from taking one drug versus another. So being able to analyze the effectiveness of the drug related in a way that's like related to its price, and weighing those things against each other. The cost effectiveness frontier is something that, okay, the cost effectiveness frontier is not on the exam. I'll just put that out there. But the cost effectiveness frontier is, it's kind of like, okay, there are maybe a set of drugs where one of them's cheaper and the other one is more expensive but better. And so you have to weigh those things against each other and try to figure it out. But there could be another drug that's like not only more expensive, but also not as good. So that drug would be wholly dominated by the other options. And there's really no reason to ever pick the more expensive, less good drug. The ones that make up the, it's either cheapest or it's the best, those are the ones that are along that frontier, where, you know, you might have a trade-off in terms of which one you value more, saving the money versus having the better drug. But either way, they're among like the options that maximize something for you. So that frontier is made up of the set of drugs that are either the cheapest or the best, but where none of them is wholly dominated by another. So those are the set of drugs that make up the frontier, the cost effectiveness frontier. But the frontier is not on the exam. Okay, just in case it's useful, I'm just going to go back through those, the 3 ways of eliciting QALY weights. So one of them was the visual analog scale, like I said, sad face, happy face scale of 1 to 10, or actually 0 to 100, same idea. Okay, the time trade-off approach is where a person has 2 options. Either you can live for some number of years with full health, or a shorter amount. Okay, live for some number of years while you're really sick. Let's say you get 10 years, but only with 1 leg. Okay, or you can live for another number of years, but in full health with all working limbs. So what would be the equivalent trade-off for you? The difference between those 2 numbers would reflect like how much worse off you are with this condition. So perhaps, you know, 10 years full health, all working limbs, or I mean, sorry, 10 years. It's hard to come up with on the fly. But does anybody have any, I wish I could see people's faces because it's kind of difficult to assess like how much of this is like landing. But 10 years, 1 leg versus 5 years full health, are those equivalent? How many years of full health, how many years of, I don't know. It's so weird to also put those numbers on a state of being because I've never had that situation before.
The hardest part with those calculations, like all the principles make sense, but when it's like, so it's like quantifying, it's like, how are you quantifying my happiness with 1 less, like it's all like, that's always like the unit part that like confuses me, like even the calculation once I know every symbol, but it's just that I'm like, is that a number? I don't know.
Yeah, it is weird. I mean, so what they do then is just like survey a whole lot of people, you know, in different countries, different like cities, different contexts, like all these different kinds of, they try to ask as many people as possible so that no one person's answer is like the definitive truth. But then once they kind of like look at patterns across and then compare between these different conditions, and they kind of get a sense of like, on average, this is what people seem to be responding. So it's definitely flawed, but it's kind of like just trying to pin it down.
Yeah.
So the time trade-off and the standard gamble are similar in that you have to kind of compare between, so the standard gamble basically is just like, it's similar to the time trade-off, except it's with probabilities instead of years. You could have some probability of full health versus another probability of having the condition, and trying to assess at what point these things are equal. So more specifically, with the standard gamble, it's like you have some probability of full health versus some probability of death, as opposed to a probability of living but with a condition versus a probability of anyway, it doesn't matter. The point is, I'm not going to ask this question on the exam in such a detailed way. It's I think that stick to kind of the concepts, what people are being asked to do. If you were ever in a situation where you needed to elicit QALY weights, which is far less likely. I mean, what's far more likely is that there are people whose job it is to establish what these QALY weights are. And sometimes there are people who make decisions, like insurance companies or in policy settings, about whether or not to cover a particular drug, and they want to collect information from all of these different ways of weighing quality of life. So you want to draw from standard gamble, you want to draw from time trade-off, you want to draw from the visual analog scale, because they're all kind of giving you different kinds of information by asking people to do different kinds of things. So whether it's weighing probabilities of health, or length of time, or just visually assessing how you feel with a certain disease, it's better to have more pieces of information because each of them are kind of doing different things. You don't need to know the intricacies of exactly who's like exactly how to pose the particular question. I want to know how people feel about the impossibility result, Arrow's impossibility result, and maybe just discuss that a little bit. So that chapter 15, where it's talking about like the trilemma and also the impossibility result, those are, and just from reading everybody's papers and stuff, I thought it might be a good idea to clarify that they're two different concepts. I mean, they're related, but they're distinct. So the trilemma is health, wealth, and equity, and the fact that oftentimes when we're trying to make a movement on one, it can require a trade-off in another. So we can give everybody really good health, maximize equity, but it'll probably cost a lot of money and would detract from people's other people's ability to maximize their wealth. So you can't really maximize all three of those things at the same time. That's what the trilemma is. It's a dilemma because you can't maximize them all, even though you value them all. The Arrow's impossibility result is more specific to kind of in that that example in the lecture where there was 3 people and their preferences about what they wanted to eat. And when you try to aggregate everybody's preferences, it's really hard to say across all people, what is the first best, what is the second best, what is the third best. There's kind of no good way to know for sure from a large group of people exactly what everybody wants to do and how everybody wants to move forward. And so you can see that in like that specific example in the lecture when it was just about, what should we eat? But also when we're talking about really complex things like trying to set up a health policy, especially when you are faced with something like a trilemma, where you have to maximize 1 or 2, but you can't maximize all 3. It's difficult to elicit from a group of people who all have their own preferences and their own ideas. It's hard to go from that to being able to really say what's the first and second and third best in order to move forward with like the most optimum policy. So it's difficult to say what is the optimum, maximum, best policies because so many different people have so many different ideas. And combining the preferences of a group it's difficult to do in a consistent way. Especially when different people have different understandings of what, like, so we can talk specifically about like healthcare policy and that trilemma. Some people would like to maximize equity and maximize health, but when we say that we're going to be drawing off of wealth, what does that mean? Are we all going to lose money? Are some people going to lose more than others? Is that going to come from those who are the wealthiest? How exactly are we going to be taking that trade-off on the wealth side? We might all have totally different understanding of how that plays out in practice. So that's part of what makes it difficult to be able to combine the preferences across groups of people, is that we don't necessarily start from the same page of shared common understanding of the problem, understanding of the solutions. So that complicates things. But basically what the Arrow result is showing us is simply that it's difficult to aggregate preferences across a group.
Could we also look at Chapter 18, differential wage pass-through?
Yeah. So with differential wage pass-through, what's happening is that, well, so first of all, wage pass-through, it's basically what they're talking about is you kind of pay, even though your employer is contributing towards the premium on your behalf, to some extent, you're paying for that, even that portion of it, because it's coming out of your salary. So your employer knows like how much you cost them total, even though some of it's going to you and some of it's going to the insurance company. It's like a total compensation package. That's how they think about it. Because if they fire you, they know how much money they will be able to save as a company. So for them, that's all money that they lose because you're there. So to some degree, your premium is actually being passed through into your wages. Now, what the textbook is proposing, and there's some evidence behind it too, about differential wage pass-through, is that some people who are perhaps healthier and they look healthier, so even if they're not, I mean, just by age, in general, younger people tend to utilize less healthcare. So employers like don't actually know who costs more than another, but they see a younger person and they assume that person costs them less healthcare. So they think that like that person is going to be cheaper. You're not driving up our insurance premiums because you cost less money in healthcare. So even though one person, when they work at a job over many years, they might, like as they have more experience at that job, they might be getting paid more and more and getting promoted. But still, if you have health insurance through your job compared to another person with your same age and experience who doesn't have health insurance through their job, that other employer who doesn't have to pay for healthcare can afford to pay their worker more and does, according to a lot of evidence. So to young people who do and do not have healthcare through their employer will have some difference in their wages. The one who has healthcare through their employer making less. To older people will have an even larger difference in the gap in their wages, where the person who has healthcare through their employer, they're going to be getting paid so much more through the healthcare channel that their wages aren't going to grow as much over time as the other person whose wages have been growing over time as they've gotten older, without some of it going towards healthcare. So the differential wage pass-through is just the fact that like a healthier versus an unhealthy person, supposedly their employer is just covering their premium, but actually the healthier person is paying less for their premium because they're getting more of it through their income. So it's just that the kind of like the price of health insurance as paid through lost wages is going to be different based on how healthy you look. Okay, we have another question in the chat. For type 1 and type 2 errors, do you want us to know what they are and how it relates in terms of drug regulation? Yeah, so for type 1 versus type 2 errors, so the type 1 error is when they have to, so you're always going to end up incurring at least one of these types of errors for the most part. But the type 1 error is when you say it's okay, but it's not. So they pass the drug, they say it's fine, but actually it's really harmful and it kills a lot of people. So imagine if they like finally created a COVID vaccination and they thought it was safe, but then it turns out people get super sick and some of them die or something like that. That would be really bad. That's a type 1 error. That's when you think it's okay, but it's not. You say that this drug is safe when in fact it is not safe. And so as a result, people take it and they get sick. The type 2 error is more passive. You know, they're super stringent about every drug, and so they end up not letting some drugs through that would have been fine. So they're overly cautious in a type 2. That could still be an error because perhaps the drug is fine, it's safe, it could have been out there helping people, making them feel better, but because we were so strict about our regulations, we didn't let that drug through. That's still an error, but it's a more passive kind of error. And it results from just super trying to avoid the type 1 error. So they're just two different kinds of errors that they can make. And as a drug regulator, when you're trying to decide like how strict to be, you have to kind of weigh those two concerns. Okay, for the Medicaid work disincentives, there is a graph in the textbook that kind of shows the, on the x-axis, labor hours, and on the y-axis, like your total assets. So if you're, you know, because Medicaid, you're only eligible if your income is below a certain amount. So if your income is below a certain amount, you can, you know, earn that income, and you also have the value of the Medicaid coverage. If you make $1 over that eligibility limit, all of a sudden you've lost potentially thousands of dollars worth of healthcare coverage. So you might have made $1 more in wages, but you have a net loss in terms of the total resources that you have access to. So that notch in that graph kind of shows like as your labor hours go a little bit over the eligibility threshold, you end up having a net loss in your total resources. So just look at that graph. And if anybody has the page number for that graph and can share it, that would be helpful.
I'll type it in the chat. It's 392.
Cool. So I am recording this, by the way, so I'll put it up on Blackboard, but so medical inflation and the price index, you want to review just like what it does and what it doesn't do. So the index itself, you're not going to have to calculate these numbers, but the way it works is that you compare prices, like some particular quantity of medical care consumption that represents maybe a typical set of medical services that a person might use in a particular year. So let's say a checkup, you know, an MRI, and a, I don't know, like a surgery or something. Not that a typical person would use, but just that like different things that people use, put them together, and then with the quantity and their price from year one, and then see for the next year, using the same quantity and the same kinds of healthcare goods and services, but at their new prices, how much of a difference would it be? And so it's strictly a way of comparing the prices from one year to the next, but without looking at any difference in the changes in quantity or in the changes in the types of healthcare that people might consume from one year to the next. So it's really specific to prices. In fact, if you look at that equation, it's like P0 Q0 versus P1 Q0. So Q is always referring to time period 0, but you're only looking at the difference in prices between time period 0 and 1. So just because it's strictly looking at differences in prices. Okay, so we've got 10 minutes. If anyone has any other questions. How do people feel about job lock Pros and cons of QALY. Yeah. So it's the exam review question was looking at like the pros and cons of the different ways of eliciting QALY weights from a population. And so there's like these 3 different ways of assessing them. I guess, yeah, we can go back to that, but there's 3 ways of assessing QALY weights. And like we talked about before, the point of assessing these QALY weights is to try to understand how bad it feels to have a disease and how much better off you are getting it treated. So it's an abstract notion and it's difficult to quantify, but we need to quantify it in order to make some kinds of policy decision. So, so there are 3 different ways in the textbook that they've talked about how they've been able to elicit that feeling from people and to quantify that feeling from people. Those 3 ways are the visual analog scale, the standard gamble, and the time trade-off. The visual analog scale is where you look at sad face to happy face, scale of 0 to 100. How good or bad do you feel? The time trade-off is like, let's say you have some particular disease. We'll just say the common cold. So let's say that you could live 10 years with the common cold or 5 years in full health. Would you consider those things about to be about equal, roughly equal, or, you know, perhaps 10 years common cold is about equal to like 8 years of full health? Because it's not that big of a difference. Like you just cough a little bit. So the time trade-off is trying to understand how many years of full health is equivalent to 10 years with this sickness. It's probably fewer years of good health because that's the kind of trade-off you would make. So that's the time trade-off. And then the other way is the standard gamble, where you ask a person to try to put some probability numbers in here. Would you prefer to have this condition with certainty, and you have to weigh that against some gamble between death and perfect health? So let's say I posed to you this like, this choice set. Either you can live for 10 years with a cold, or you can have 50-50 shot of either dying immediately or living 10 years in full perfect health. Would you take that trade-off? Would you take that coin flip? Or would you be like, no, I'll just take the cold instead of having a 50% chance of dying, But then on the other hand, what if I said, instead of just a common cold, let's say it was like some severe excruciating illness. And on the other hand, a 50% probability of dying versus a 50% probability of living the rest of your life in good health, then you might actually think that, okay, 50% chance of death isn't that bad. Well, what about if you had an excruciating illness and a probability of death of only 10%, as opposed to 50-50 a coin flip, or 5% or 1%? What is the probability of death in that gamble that would make you want to take that trade-off compared to this condition? If you're only willing to take the gamble when there's a very small chance of death, then the illness is probably not that bad. So each of these has their own pros and cons. The visual analog scale is just really simple, and that's the benefit of it. Sad face to happy face, scale of 0 to 100, how bad do you feel, is really easy for people to answer. And so that's a definite pro. But then a problem with that is that it doesn't really force you to compare between 2 things. So if you have like a stomach ache or something, and people are like, then they're like 0 to 100, how bad do you feel? You might be like, oh, 60, 70. But then if you have some kind of like really bad cut, you might say, ooh, this is a 50, Maybe if you have cancer, you say, it's like a 45, Is a cut in cancer really just a difference of 5%? Not necessarily. you know, because you're not making that direct comparison when you're answering the question. You're just kind of like grabbing a number out of nowhere. So it's really simple, but it's also not very accurate, the visual analog scale, because it doesn't force you to make any kind of comparisons between different kinds of health states. The standard gamble and the time trade-off, in both of those instances, you are making at least some kind of trade-off between, you know, either the probability of good health versus death, or the amount of time that you would spend in good health. And so it forces you to make that trade-off, and so in that sense, it ends up being like a little bit more accurate. People are better at differentiating between really bad illness and really not that bad illness when they're doing those trade-offs with the time trade-off and with the standard gamble than when they're just doing that visual analog scale. People just end up kind of saying, middle, like a little bit over to there, a little bit over to there, but the distances between these illnesses don't actually reflect like anything meaningful in terms of disease severity. So the trade-offs become important.
Professor, can you explain again the graph for the Medicaid notch?
Yeah, so it's on page 392 of the textbook, somebody said, so let me pull that up on this other computer I'm looking at. We've just got 3 minutes, so we're gonna have to end with this. If you have any other questions, put it in the chat. So the notch on the Medicaid picture, along the x-axis of this graph is L, which is labor hours. And along the y-axis, it's assets. This is both the income that you're making from your labor hours and also your healthcare coverage. Now, when your income is below Medicaid eligibility, because you know with Medicaid, you have to make less than a certain amount in order to be eligible to have this coverage. It's meant to be aid for low-income households. So as long as your income is below that amount, you're good. You have both your earnings from your job and you have the value of this healthcare coverage. Now, if you end up working one extra labor hour to where your income is now above the threshold for Medicaid eligibility, you might have made one more hour's worth of money on your paycheck, but you've lost something very valuable, which is the value of that healthcare coverage. So in terms of your total assets, income plus healthcare coverage, you lose. You know, earning that one more dollar, working that one more hour actually causes you to have a net loss in the total value of assets that you have, because you've automatically lost thousands of dollars of healthcare, even though you've made 10, 20 more dollars out of one more labor hour. So that notch is what happens, is what reflects that, because the y-axis drops down whenever the x-axis moves up a little bit more. So you get one more labor hour and then the y drops. And so that's the notch.
You said the y-axis drop whenever the x moves up.
Yes, right at the point of L1, if you're looking at the picture, when you move to the right of L1, then on the y-axis, assets drops down. That's what that notch is.
Okay, thank you.
Mm-hmm. I think that's about it, because there's only a few seconds left. So you can email me if it was not clear. And
thanks, Professor, for your time.
Thanks, everybody.
Thank you.
Have a good week.
Thank you.
Thanks, guys.